may be useful for the anesthesiologist. So just starting off, I think a lot of us have wondered how useful is lung ultrasound in an anesthesiology practice? These are questions I asked as I thought how to apply some of these tools to my anesthesia practice. I also wanted to consider, are these skills obtainable for the average anesthesiologist? Are these going to be convenient? Are they going to be reproducible? And what are some of the studies and evidence that have been performed to support the use of lung ultrasound? So we're going to start off today with a case. This is a case that I saw personally. It's a 26-year-old man who was admitted with a severe TBI, and due to respiratory failure in the ICU, he needed a tracheostomy. When he returned to the neurocritical care unit, he developed worsening hypoxemia, and we worked it up with the following chest x-ray. If you look at this chest x-ray, you won't find any clear pleural lines that the radiologist would call as a pneumothorax. The radiologist, in fact, called it a fairly normal chest x-ray. But you can appreciate that the density of the lung tissue is a little bit asymmetrical. The patient ultimately went on to get a CT scan for an unrelated purpose, and this is what was found on the CT scan. And what you can see here is that there is a large pneumothorax on the left side of the chest. One thing I'll also note is that the air is present just in the top of the lung, in the most anterior portion. And if you look across the screen, you can see that there is lung present all the way across the chest wall. And that's why there was no pleural line and no absence of lung markings seen on the chest x-ray. So this CT scan made the diagnosis, and then we placed a pigtail chest tube, which can be seen on the image on the right, and there was resolution of the pneumothorax, and you can appreciate that now the lung aeration on both sides of the chest x-ray is symmetrical. This case is important because it demonstrates one of the significant limitations of using chest x-ray to diagnose pneumothorax. And as you can see, the way that people are positioned with chest x-rays and CT scans, when they're in a supine position, as our patients often are in the OR, the air can hide at the top of the lung, and you can get lung markings throughout the chest that hide potential pneumothoraces. So what are the consequences of this limitation for us as anesthesiologists? Well, here is an example of one. So let's say a patient develops a pneumothorax during a case, and during a general anesthetic, positive pressure ventilation is delivered. Over the course of the case, the patient may become increasingly hypoxic, increasingly hypotensive. There's a broad differential for those findings. But here's an example of a patient who had a severe tension pneumothorax where the heart was completely relocated to the left side of the chest, and you can see significant tracheal deviation. This is a life-threatening complication. So you definitely don't want to be missing pneumothoraces. On the other hand, you also have to consider, is a chest thoracostomy truly indicated? False negatives are a big problem, as seen in the last image, but in this image you can appreciate that a false positive could be a problem too. A chest thoracostomy is not a benign procedure, and if we put chest tubes in every patient we suspected had a pneumothorax, we could cause some harm. An example of this, and something I wanted to bring up during this talk, is the idea of capnothorax. A capnothorax during laparoscopic surgery may appear identical to a pneumothorax. It's ultimately air or CO2 that's come up through a defect in the diaphragm and surrounds the lung. It would be indistinguishable based on ultrasound or chest x-ray from a pneumothorax. However, we treat capnothorax by increasing the PEEP, reducing the insufflation pressure, and using the pressure differential to push that CO2 back out of the pleural space into the abdominal cavity through the existing defect in the diaphragm. And these patients should not require a chest tube, generally speaking. So you can see that we're looking at trying to diagnose pneumothoraces with a good amount of sensitivity and a good amount of specificity. So getting into our first set of studies, a Cochrane review was published in 2020 looking at the ability to diagnose pneumothoraces with chest ultrasound versus chest x-ray in the trauma bay. And there have been multiple other studies done in other situations, but they all have similar results. And what you can see here is that among trauma patients who are being evaluated with a chest x-ray and chest ultrasound, and then ultimately go on to get a CT scan, which is the gold standard diagnostic test for a pneumothorax, the sensitivity of lung ultrasound is 91% compared to the chest x-ray sensitivity of 47%. So essentially what that means is that if you use chest x-ray alone, you will have a lot of missed pneumothoraces. And those patients, as they come through the trauma bay, may become our patients. Certainly a trauma bay patient with a missed pneumothorax could be wheeled directly to the operating room for any number of urgent procedures, after which we intubate that patient. And then if they develop hemodynamic instability or hypoxemia in that situation, the consequences are ours to bear alone. So we're certainly stakeholders in this question of making sure that we're not dealing with undiagnosed occult pneumothoraces in the patients that we bring from the ED directly into the operating room. So now I'm going to talk a little bit about the pneumothorax assessment by lung ultrasound. And many of us are aware of lung sliding. But fortunately or unfortunately, as we've been doing research into diagnosing pneumothoraces, getting that high sensitivity and specificity that we need, we actually need to look for at least 4 different findings, which I'll lay out for you in detail. And I'll show you how to navigate those findings in a diagnostic chart that allows us to essentially generate a pathway for the diagnosis or exclusion of pneumothorax. So the key components are 1, lung sliding, which many of us are familiar with. There's also the presence of B lines, which is another finding. Lung point is essentially the confirmatory finding that really rules in pneumothorax. And then lung pulse is another finding that can be found in a confounding situation. So you can see here, if we start at the top left-hand corner, the first evaluation is lung sliding. If there is lung sliding, there's no pneumothorax. Now the caveat with the little red asterisk here is that in order to make this study sensitive and specific, you need to be looking at the uppermost region of the lung, meaning the area in which the air will rise. Like seen on that CT scan, this is the least dependent area of the lung. So assuming that you're looking in the supine patient on the anterior chest wall and a more upright patient up more towards the apices, you're going to be needing to look in the area where air will naturally go. So if lung sliding is present, then there's no pneumothorax. Certainly B lines can only be seen with lung sliding, and those also exclude pneumothorax. If you have an absence of lung sliding and B lines in a certain area, then you look for the lung point, which clinches the diagnosis. And you can see that takes you over to the right side, and that confirms pneumothorax. However, there's also an ambiguous situation in which you have no lung sliding, no B lines, and no lung point. And then you look for a finding called a lung pulse, which is actually suggestive of a main stem intubation and can prevent you from putting unnecessary chest tubes in when you're looking for pneumothorax. So we're going to go through some of these findings in detail and a little bit about basic lung ultrasound. So this is one of the first slides that most people see when they're learning lung ultrasound. And I will say the caveat here is that lung ultrasound is a hands-on activity. It's best learned outside of a pandemic in a group of people where unfortunately you have to get close. And so for this talk, I'm going to show you some of the basic findings, but keep in mind that you'll need some hands-on practice before you can implement these things. So the basic view for a normal, well-aerated lung starts here. And you're essentially starting with putting the ultrasound on the chest wall, perpendicular to the directions of the ribs. And so you can see in the upper left and right corner of the image, there are two ribs, and they cast a rib shadow. And the idea is that you point your ultrasound beam between the two ribs that allows you to look into the chest. And the first thing you'll see is that the upper white line, indicated by the upper set of small horizontal arrows, that's the pleural line. Below that is an artifact. It's a reflection of the pleural line due to reverberation artifact, and that's called an A line. So an A line is a normal finding. And this has an absence of signs of pneumothorax. It has an absence of signs of volume overload. That being said, pneumothorax in a still image can look much like this. So in order to have more specificity, we're going to have to look at some videos. So moving on here, I'm going to show you what lung sliding looks like. On the left image, what you can see is that above that white pleural line, there's very little movement. And that's tissue that you're probably familiar with seeing as immobile tissue, like if you're doing a nerve block. And what you see below that is a shimmering, and that's because the interaction between the ultrasound beam and air creates a lot of artifact and doesn't create any meaningful definition. You'll see shimmering of the lung where that air tissue interface occurs at the pleura. Now, in contrast, on the right side, I have a patient with a pneumothorax. And what you can see in contrast is that even though there's movement, you don't see specific lung sliding. And I'm going to show you this again because it can be a little bit difficult to appreciate. So this is a zoomed in version. And notice on the left, we'll start with lung sliding. And you'll see that shimmering in the lower part. And you'll also see some movement that we sometimes call ants marching. And it almost looks like an ant is marching along the base of the pleura. And then on the right, again, a patient with a pneumothorax. We see an absence of lung sliding. And we don't see that same type of shimmering effect below the pleural line. So this alone is not enough to make the diagnosis of pneumothorax. And that's a key point I want to make today. So some of you have seen M-mode. And M-mode allows us to make a similar evaluation. Essentially, it's the same image, and we're collecting a single line of ultrasound signal and projecting it over time. And so on the left side, what you can see is what we call the beach appearance, and that's normal. And so the top half of the screen looks like waves, and that represents that over time, the tissue is not moving. And so you get this wave effect. Below the pleura, which is represented by the red arrow, you can see that we have what would be thought of as sand on the beach, and that's kind of that fuzz. It's almost like TV static, which is that shimmering artifact of the air interfaces that normal lung generates. Now, when you move to the right side, you can see what we often call the barcode sign, which is essentially that the water extends all the way down. And you can see that there's an absence of sand here, and so what that means is that over time there's very little movement. And so that's what M-mode does when there's very little movement, is you'll just see a series of horizontal lines, specifically in the lower half of the image, below the pleural line. So the next thing we may look for is this idea of a lung point. And the lung point is probably the most challenging of these images to find because it exists at a specific location in the chest wall, and you often have to hunt for it. So keeping in mind that air rises to the top, I want you to imagine this chest CT of this patient with a pneumothorax with the lungs slowly expanding and contracting with each breath. And you can imagine that there is going to be an interface kind of a triple point between the chest wall, the lung, and the air. And you can see that little black triangle where I have a probe looking at that exact location. And that as the lung inflates and deflates, that point is going to move up and down. And so you'll actually see on the ultrasound beam a distinct interface between lung going up and sliding against the chest wall and the absence of lung, which is air. This also shows why we need to look at the non-dependent portion of the lung, because if you looked for your pneumothorax in the back of the lung, in the posterior position, you would see normal lung sliding, and you would be falsely ruling out the pneumothorax. So I'm going to show you a lung point. And these images so far we've obtained using a butterfly probe, one of these portable probes. So the image quality isn't the best, but I wanted to use something that people would be used to seeing, and also to make all of these findings seem accessible and independent of the quality of the ultrasound machine you're using. So here's our lung point. Again, you're going to look for the ants on a log and then a distinct transition point. So you can see that with each breath, the lung sliding is moving across the screen. And some people call this a curtain sign. It's like opening or closing a curtain on a window. So this finding, rather than lung sliding, is pathognomonic for pneumothorax. And this finding is what buys your patient a chest tube. And that's extremely important because when you see this finding, you can have absolute confidence that there is truly a pneumothorax, assuming that this is, again, not a capnothorax during a laparoscopic case, and you can put that chest tube in knowing that you're not exposing the patient to an unnecessary procedure. You can also appreciate the lung point using M-mode. So if you can imagine in that previous image, let's say we suspended our M-mode line in the middle of the screen, and our lung, our pleura is sliding in and out of that line. You can get the finding on the right side, which on the right half of the image, you can see in the left portion, you have your sandy beach. And then on the right portion, to the right of the vertical arrow, you can see you transition to the barcode sign. This finding would also be pathognomonic for pneumothorax and would be another way of confirming and documenting the lung point. And ideally, as we move more into ultrasound, there will be opportunities and easier ways to document these findings and have them in the medical record as a way to show that we're doing our due diligence to identify these diagnoses and making sure that those findings get documented appropriately. So now I'm going to move on to another finding. This finding isn't traditionally thought of as a finding for pneumothorax, and these are called B lines. So the two major artifacts that are most commonly seen are A lines, which we saw before. Those were those horizontal lines that are a reverberation artifact, and an A line can even be seen on the middle right-hand side of this screen. The B line on the other side, on the other hand, is an abnormal artifact, and what it represents is the presence of fluid or increased density in certain regions of the lung near the pleura. Again, we can't say much about what's going deep inside the lung, but in this case, this patient has pulmonary edema. And if you think about curly B lines, actually as findings of pulmonary edema that were seen on chest x-ray, those are tending to form on the outside of the chest x-ray. This is almost an ultrasound equivalent of that. And so what you can say, though, is that as you look at the B line, and the B line, also sometimes called a comet tail, there is the ants marching on a log phenomenon where you can see the lung sliding. And additionally, you can see that the B lines move with the ants. So essentially the B line moves with the pleura, and the B line is a specific portion of the visceral pleura of the lung that has that increased density moving back and forth. And so this is almost a proxy for lung sliding. And so what you can say is that if you see lung sliding in your non-dependent area and or you see B lines, both of those exclude pneumothorax and you don't need to go hunting for a lung point. So because a B line is starting to look more at the lung interstitium, I'm going to tell you a little bit about some other findings that are seen in lung interstitium. Now, this is getting a little bit further away from anesthesiology, a little bit more towards ICU or pulmonary medicine, but these are important basic findings that you should be aware of, and these could be important in preoperative evaluation or intraoperative evaluation of unexplained hypoxemia. So some of the key artifacts, we talked about B lines, which represent lung density or water. There's also this nomenclature for hepatization. If you've ever looked at a liver through ultrasound, you know that it has a distinct appearance, and the liver doesn't contain any air. And so when a portion of lung becomes completely filled with fluid and there's no air in that portion, it looks like the liver, and that's hepatization, and that's a finding consistent with consolidation or complete loss of air filling. You'll also see some pleural changes. The pleura that we looked at for the first few images, those were pretty smooth pleura, and we'll show you some examples of some pleural changes that can indicate that there's some lung inflammation and pathology happening. Now the important thing is that as you move from looking at pneumothorax and ruling in or out pneumothorax, the distribution of your findings becomes more important. If we're looking at the lung interstitium as a whole and asking the question, what's going on with our lungs, we actually need to look at several areas of the lung and compare those areas to help us make a diagnosis. And so there are 4 zone ways of doing it. There are 6 or 8 zone ways of doing it. Essentially, you need to do probably at least 4 to 6 general zones of the lung, anterior, posterior, mid-axillary, upper and lower, in order to consider how whatever process is happening is affecting different lung tissues. So to give you some examples here, we have essentially a continuum looking at water filling up the lungs and causing increases in lung density. On the right-hand side, we have our normal finding, which is just A lines, no B lines. As you move from the right to the left, you get a loss of aeration, and you can see lots of B lines. And again, more B lines actually correlates with an increase in water content. A single B line, especially in a dependent area of the lung, can actually be normal. And that's just that's just atelectasis. Atelectasis causes B lines. So when you're looking in non-dependent portions and you're seeing multiple B lines, then you're getting a little bit more concerned that you're losing aeration. And then eventually, with more aeration loss, you'll see coalescent B lines, which are sometimes called C lines. And then on the left, you can appreciate consolidation or hepatization. So you can see that the pleura is marked with those little arrows, and below the pleura, you're almost seeing what looks like liver tissue. And on the top one, you have lobar consolidation, which would be a whole lobe is just socked in with no gas exchange happening. And then you can also get subpleural consolidation, which I'll show you on the next slide, a CT scan of what that looks like. So to make things relevant for the pandemic, and as people have been publishing loads and loads of research around the pandemic, a group correlated ultrasound findings with CT scans. And you can see, I think this really nicely demonstrates the correlation between the CT scans and the types of consolidation we see and the findings that are seen on ultrasound. So starting in the top left, you can see the red box on the CT scan correlates to the ultrasound image. Those are just A lines. So top left, that's essentially normal lung tissue. This is a very mild case of COVID. And you'll only appreciate it if you looked on the left side of the chest, which is in A3. You can see a small area of subpleural ground glass opacity. And so that's just an idea, that's just indicating that there's a little bit of fluid in there and you're starting to see some B lines. As you move to the BCT scan, you can see on both sides you're seeing more diffuse B lines, and that's consistent with a deeper degree of ground glass opacity, more continuous ground glass opacities, consistent with an even greater degree of lack of aeration. Moving down to the C category, you're starting to see some areas on the CT scan, especially on the left side, that are completely white, or just around the edges in that most dependent area, and that's showing that subpleural consolidation as seen in image C1. And then on the right side, you're seeing less distinct complete collapse and more diffuse disease, and again, you're seeing those coalescing B lines, almost a C line. And then finally, moving on to C5, this patient has undergone severe consolidation in the bases, again in that dependent position, and you're seeing hepatization of the lung on C4 going down more deeply, and then on C6, again with the subpleural consolidation. These are more advanced findings and maybe a little bit out of the scope of the average practice of an anesthesiologist, but I think it indicates how we think about B lines and how there's a spectrum, and I think that's important to consider when you're comparing different patients or even different regions of the lung that you're looking at on the same patient to get a sense in your head of what these CT scans might look like, since these artifacts that we're looking at are not really anatomical or intuitive in terms of our understanding. So we've talked about B lines, we've talked about lung sliding, we've talked about the lung point. That leaves our last finding, which is probably the most obscure finding, and this is called the lung pulse. And what the lung pulse indicates is that the pleura are approximated, there is an absence of air, but they are not sliding. And this can happen for a few different reasons. And so when you put this on M mode, what you'll see, looking down at the bottom, the yellow arrows indicate a rhythmic, subtle change in the M mode profile that exists only beneath the pleura. So the pleura is indicated by the triangles on the end. You can see you have the barcode kind of waves above the pleura, and below the pleura you're just seeing these little, what are essentially heartbeats. And so each ventricular contraction transmits force through the lungs and will cause a little bit of lung sliding, even if the patient is not being ventilated. So that is one of the reasons you might see this finding, is if your patient is, say, completely apneic. Apnea is certainly a cause of a lack of lung sliding. And the difference between lung sliding and lung pulse is that the frequency correlates with lung sliding with the respiratory rate, whereas lung pulse, it's the heart rate, and then the movements for lung sliding are large and the movements for lung pulse are very small. So we're going to take this back because I think it's helpful to look at this image, showing that the only reason you would need to do a lung point is if you saw no lung sliding and no B lines. And the only reason you'd need to do a lung pulse is if you saw no lung sliding, no B lines, and no lung point. And for anesthesia, especially at a teaching hospital, you may find that one of the reasons that you may have no lung sliding, no B lines, no lung point, and a positive lung pulse is a main stem intubation. And so, like apnea, this is a situation in which you're not ventilating the lung that you're looking at. So this has been studied, and it was done at an academic institution and published in Anesthesiology. And the authors of this study put together a protocol where they used two techniques. The first step they used and I thought it was worth a brief mentioning, is that you can look for an endotracheal balloon with an ultrasound through the neck, through the trachea, anteriorly, to confirm the placement of an endotracheal tube and the position of the balloon. Furthermore, step 2, you can see we're essentially in the algorithm that we laid out. We're looking at lung sliding, we're getting M mode and looking for those cardiac movements that we saw with our lung pulse, and using these two things together to try to rule in or out a main stem or bronchial intubation. Because we hadn't had a chance to look at it yet, I wanted to show you in real time what endotracheal balloon ultrasound looks like. And so actually going back, I want to show you the image on the top left. You can see that the probe is placed perpendicular to the trachea and scans up towards the cricoid cartilage. So showing the image that results from that scan, you can appreciate a widening of the trachea as you pan up and down. And what that shows is that, in fact, when you intubate a patient and inflate the cuff in their trachea, the trachea actually expands in the region of the cuff. And so if the cuff is high enough, if it's above essentially the sternal notch, which would be desirable, that confirms that A, your cuff and therefore your tube are present in the trachea. So this is useful as a way to rule out esophageal intubation for new intubators. And then also the presence of the cuff above the sternal notch also indicates that there is not a main stem intubation. So in this study, they actually simulated right main stem intubation, presumably with informed consent, and they compared our traditional technique for diagnosing main stem intubation, which is auscultation, versus ultrasound. And again, using those two steps, one looking at the balloon and the other one looking at our lung sliding and lung pulse. And so what they found was that using ultrasound to rule in or out bronchial intubation had a very high sensitivity and specificity, greater than 90% each. And while auscultation had a pretty good sensitivity, it had a low specificity. And what that meant is that essentially, because you can sometimes get confused with breath sounds being transmitted from the other side of the chest, you're not always able to hear asymmetrical breath sounds. Certainly in a loud OR, which sometimes during induction or shortly after induction there can be music or loud noises that make it also particularly challenging. So this shows another opportunity using the principles that we saw to rule out pneumothorax, that in the absence of lung sliding but the presence of a lung pulse, you can make the diagnosis of bronchial intubation, and then instead of putting a chest tube in a main stem patient, you can pull the tube back, resolve the problem, and again, you're avoiding those false positives and the repercussions therein. I also wanted to show you one last little finding, just to squeeze it in here, is the pleural effusion is also important and easy to see. What you can see in this case, on the right-hand side of the screen is the diaphragm. This is looking at the lung posteriorly, generally in a patient that's sitting up. That's the easiest way to see this. And the characteristic sign is that flapping triangle is the base of the lung, which has collapsed because of the surrounding pleural fluid. And so this demonstrates hepatization of the collapsed lung. You'll notice that that lung looks more like the liver, and conveniently the liver is seen on the right side of the image, so you can make that comparison, the liver under the diaphragm. Interestingly, it also appears that there's some fluid between the liver and the diaphragm. Typically, in a normal case, the diaphragm sits directly on the liver, and you don't see that extra fluid. So this image shows a few different findings that are also interesting and certainly part of lung ultrasound. This could be important for us, certainly, if there's a hemopneumothorax that develops after a central line or with a trauma patient, that you can screen for pleural effusion in addition to screening for pneumothorax. So speaking of central lines, I think one of the most apt ways to integrate lung ultrasound into an anesthesia practice is to consider some of the risks that we absorb when we place central lines. Both placing central lines in the OR before or after induction, and also central lines that are placed in the emergency department for urgent cases, especially trauma cases. So certainly in most of the institutions I've worked that have trauma centers, central lines placed in the ER or in the OR prior to surgery are often used without verification. And verification in terms of the standard of care typically means some sort of screen for pneumothorax and identification of where the tip of the central line is. And when we place central lines in the hospital, on the floor, in the ICU, we typically use a chest x-ray. And in many cases, it's a supine chest x-ray, which, as I mentioned before, has its own issues with low sensitivity for pneumothorax. And so this particular situation leaves us opportunity to develop strategies to keep our patients safer and reduce some of the complications we do see from central line placement. So to further characterize the risks and the problems, an undiagnosed pneumothorax, either from chest trauma, rib fracture, or iatrogenic from placement of a central line, typically more common with subclavians than IJs, but can happen with IJs. When we take these patients and we subject them to general anesthesia, an undiagnosed pneumothorax can inflate due to a transition from negative pressure to positive pressure ventilation. This can occur steadily throughout the case and can create life-threatening hemodynamic instability and hypoxemia during the case. And it can be very difficult to diagnose because in most cases, say like trauma laparotomies, you're not able to obtain a chest x-ray in the middle of the case. And furthermore, even if you were able to obtain a chest x-ray, there's problems with sensitivity issues. And furthermore, catheter malposition can be a big problem. Let's say your catheter is in the mediastinum or it's in the artery. That can lead to mediastinal bleeding or a failure in drug delivery. Certainly if you are delivering pressors out extravascularly into the chest, that's a big problem. So how can we utilize some of these developments in ultrasound to help reduce these risks for our patients? So some would say that routine use of lung ultrasound to screen for pneumothorax after central line placement is a standard of care. That's not adopted at every institution, but for some institutions it is the standard of care, and I think things are generally moving in that direction. Furthermore, our cardiac anesthesiologists use transesophageal echo to confirm placement of their central lines. But in the absence of a TEE, you can also use a transthoracic probe, the same probe you're looking at the lungs with, to do a less precise but still useful confirmation of central line placement by instilling saline and watching for that saline using any number of views where you can see the right side of the heart, subcostal or parasternal. Certainly, if these practices are not universal at your institution, you could consider using them in all cases, or if you're just starting to add this to your practice, you could certainly consider doing them after difficult line placements, especially when you're supervising inexperienced residents and wanting to give yourself that extra peace of mind that you're proceeding through the case with a line that's in the right spot and you don't have a pneumothorax slowly growing. So we already talked about how to diagnose pneumothorax, but that second piece that's a little more advanced is this idea of flushing saline through the tip of the catheter and looking for what some people call the rapid atrial swirl sign. So this is demonstrated in a number of studies. Some of the caveats for it is that it does require some basic ultrasound skills, and typically it's a second operator that needs to do this. This shows a subcostal view that's basically a 4-chamber subcostal view. And you can see on the left, that's your pre-injection finding. On the right side, that's your rapid atrial swirl. You don't really have to agitate the saline, just squirting saline in is enough to be visible. And then just to show that in video, you can see this is a apical 4-chamber, and you can see the right side of the heart filling with bubbles. So this has also been studied, and in using residents who are learning, they essentially had them do this technique. And what they looked for is that they wanted to see that flush come within 2 seconds of injection. And if the flush was absent or delayed, that indicated that the central line was not in the right spot, and that you could adjust the central line or restart the procedure, depending on what you found. And what you can see, there was a baseline reference cohort in light gray, and then there was a test cohort in black where they were using this technique, and zone B being the most desirable location for the tip of the catheter at the SVC atrial junction. There was an increase in zone B placements and a decrease in other placements as seen on confirmatory chest x-ray. Some other ideas have been proposed. I think there's a lot in lung ultrasound that has maybe more questionable utility. An example for that is double lumen tube placement. A study was published that showed that lung ultrasound is superior to auscultation for assessing one lung ventilation. It was a randomized control trial. But it begs the question, we don't really use auscultation to place our double lumen tubes. We usually use bronchoscopy, so does this really add anything? That being said, like we saw with main stem intubation, which is really just a version of one lung ventilation, absent lung sliding prior to incision does confirm that your lung isolation is working, but there's some technical issues because you may not have access to the surgical field during prep to actually get your ultrasound probe on the chest. So these are just ideas that are out there, probably not game ready here. So to make some key points, lung ultrasound can be challenging and have a steep learning curve because it relies on some dynamic assessments that you have to practice and get an eye for. Also, you're mostly interpreting artifact, which is not intuitive for most of us. Artifact at the pleural interface specifically, and extrapolating from that. So that also adds to the steepness of the learning curve. However, because most of us are getting more ultrasounds, more portable ultrasounds, there's increased sonocyte availability, medical students are being taught ultrasound curriculum, including lung ultrasound, it's becoming the standard of care, and there's growing evidence and robustness of the protocols therein. This is becoming a more useful tool and something that we will see an increase in. And so looking at some of the evidence that's growing, there was an international review of the evidence, and that panel came up with essentially they rated the evidence for strength using the typical ABC that you'll see in these sort of strength of evidence analyses. And some of the key findings were that lung ultrasound should be used in clinical settings when pneumothorax is in the differential diagnosis. It's generally faster and has improved sensitivity over chest x-ray. Lung ultrasound is more accurate for ruling in and out the diagnosis of pneumothorax compared to especially supine chest radiography. And that for us, in our practice specifically, this effect is magnified because in the OR, we may not even have chest radiography available. So if we're flying blind, the advantageousness of lung ultrasound for pneumothorax is more apparent. So this is just kind of a fun slide from the Lancet. A lot of people are thinking about the handheld ultrasound device as the next evolution of the stethoscope. And I don't really see why this won't be the case. We are looking at the lungs with greater resolution. Instead of listening to S1 and S2, we are seeing the heart moving. Instead of listening to breath sounds and crackles, we're seeing the density in the lungs. We're seeing the change in movement, the change at the pleural interface. I believe this is the future. There's still more science to be done, and some of these protocols have to be nailed down a little better. And there's a lot of training to do. There's a lot of training to do for our faculty and staff. Medical students get this training, but as this becomes more widespread, we're going to need to train existing anesthesiologists, and that's one of the purposes of this talk, is to give you a sense for what might be coming and what are some of the basic features that you'll want to learn. So thinking about some future directions, and really this is expanding what lung ultrasound can do. These are things that are outside of this entry-level, really high-quality evidence-based practice, like pneumothorax, for example. Some of these things are evolving, but I think they're interesting and useful, so I wanted to mention them here. Certainly, like looking at the B lines and C lines and consolidation, we can look at interstitial lung conditions, acute hypoxemic failure. You can potentially differentiate cardiogenic pulmonary edema from ARDS, from lung consolidation or pneumonia, and those have clinical implications for some of the critically ill patients we take to the OR. You could track lung aeration by looking at the evolution of B lines as you resuscitate a patient to see if your fluid's going into the vessels or ending up in their lungs. And then there's two protocols that I think are very interesting. The Blue protocol you may have heard of. This is an assessment of acute respiratory failure, and the Falls protocol, an assessment of shock, trying to utilize some of these things that we've seen. So just to give you a sense here, I mentioned before that looking at the lung parenchyma, you need to look at different zones on both sides. And so this Blue protocol was published in the early 2000s, and it shows essentially these profiles. So you're looking at the lung in 4 spots. The patient on the left is completely normal. The patient in the middle has B lines everywhere, which is consistent with a diffuse process like pulmonary edema. And then the AB profile, you can see the patient only has impacted in the left lung, which is less suggestive of pulmonary edema. And essentially, you take these profiles that you create using A lines and B lines and other findings. You add in a few other things like looking for DVTs, which there is a point of care point check for DVTs, and then you use that to try to differentiate acute hypoxemic failure, usually in the ED, but certainly we get some of these patients in respiratory failure who are coming straight to the OR who could benefit from this type of assessment. So we have some idea of what we're dealing with. So the Blue protocol is recommended reading if you want to dive further into this. And then taking it one step further, by the similar authors, the Falls protocol is actually looking at shock. So this, you put in some basic point of care cardiac echo, looking for things like tamponade and RV dilation. You add in your Blue protocol to look for pneumothorax, to rule out obstructive shock, and then cardiogenic shock related to pulmonary edema, and then hypovolemic shock. You would see a normal profile with just A lines that would improve with fluid. And then you could look at some of the limitations of distributive shock in terms of increasing B profiles as you're resuscitating and using that as an endpoint for resuscitation. So that's kind of some of the more advanced stuff just to pique your interest. And that's really the intent of this presentation, just to say what's out there, get you guys interested in it. Know that learning these techniques does require hands-on practice. But these skills and the equipment are becoming more obtainable every day. And consider becoming an early adopter. I think there's very little to lose. These can be integrated quickly, certainly into your central line placement practice. The ultrasound is just sitting there, you're already using it. So these are some important things to consider. So these are some additional references if you want to read more about how some of this evidence was obtained. And thank you very much for your time.